Good afternoon. Welcome to Hofstra University's Public Health webinar. My name is Isma Chaudhry, and I'm the Director of Public Health Programs and an Adjunct Associate Professor in the Department of Health Professions at Hofstra. I'm happy to present and discuss the two widely debated topics of immigration and healthcare. Today's presentation will focus on healthcare challenges encountered by the diverse migrant populations in the United States. Capturing the implications of health on immigrant populations is too wide a topic to cover in less than an hour, but I will do my best to address some of the key issues and would welcome questions in the end. You can type in your questions in the text box, which is on the left of your screen. So the United States is experiencing a renewed period of immigration and immigrant policy activity, as well as heightened enforcement of such policies. Unfortunately, this intensified activity can affect various aspects of immigrant health, including mental health. We see in a wide spectrum of news media reporting on the topics of immigration, and that spectrum ranges from very liberal to very conservative narratives. Immigration policies have led to a set of dilemmas and issues associated with delivery of care to immigrants by providers, public health practitioners, health promoters. However, little is known about the most recent immigration policies and their potential impact on services and health outcomes among undocumented immigrants. Some of the most recent immigration policies are highly subjective standards for enforcement, which makes it easier for immigration personnel to enforce these policies and in turn have the potential to expose immigrants to increased profiling and potential discrimination. Furthermore, there is a legitimate concern that people who are potentially subject to delegation of Immigration Authority Section 287G, Immigration and Nationality Act by ICE, whether they are documented or they are undocumented, may refrain from seeking vital services, including medical services, for fear of exposing themselves or their family members to legal sanctions or harassment. The terminology: citizens, immigrant, non-immigrant, refugees, undocumented immigrants, asylee, people with limited visas, temporary workers, visitors. The political interchange of these terminologies has confused service providers and policymakers. The bottom line is that they all need healthcare at some point. Anti-immigration policies and departmental policies with anti-immigrant rhetoric are a major global determinant of health, particularly mental health. Undocumented immigrants were more likely to screen for depression, anxiety, PTSD when compared to other documented immigrants and citizens. Refugees and asylees leave their countries because of fear of persecution, war, fear of being killed, hurt because of their race, nationality, ideologies, political opinions. And unfortunately, some immigrants perish while traveling to the country where they hope for employment, including hundreds of fatalities in recent years at the United States-Mexico border. Why do people move? Mostly to live in areas where they can seek comfort and a better future. We live in an era of unprecedented human migration, and people move from their countries of origin because of war conflict, natural disasters, family reunification, violence, exploitation, for better economic opportunities, for food, water insecurity, poverty, discrimination, stigmas. Approximately 250 million people live outside the country where they were born. Although millions are forced to leave their homes because of violent conflict or natural disasters, the main reason people migrate is search and hope for a better future. One in every 113 people on Earth is an asylum seeker, internally displaced, or a refugee. And about 65 million people worldwide are forcibly displaced. Migration brings large benefits to migrants and to the countries involved, the country of origin and the country of displacement. But it also brings challenges. Migrants from the poorest countries, on average, have experienced a 15-fold increase in income and a doubling of school enrollment rates and a 16-fold reduction in child mortality after moving to a developed country. In countries of origin, migration lowers unemployment, open access to more productive and higher paying jobs. Migrants' remittance offer tangible benefits to origin countries. It's important to note that migration also facilitates trade, investment, and transfers of technology. So, what are the contributions of immigrants? They fill the labor need, pay taxes, of course, add diversity, enrich the culture. Many rich countries, such as United States and emerging economies, need immigrants to replenish their aging workforce. So they definitely do offset an aging population and, of course, strengthen global connections because of their connection with their countries of origin. In destination countries, immigration increases labor and skills supply, innovation, entrepreneurship, and a recent OECD report demonstrated that immigration provided a net positive fiscal effect. So, how does this information helps us? Well, this information helps us understand the right narratives. Knowing the challenges helps us understand the impact on health and helps us explore and implement avenues and policies to provide efficient and equitable healthcare. All these important variables factor into health outcomes in immigrant populations. The migration trajectory can be divided into four components: pre migration, migration, post migration, and resettlement. Each phase is associated with specific risks and exposures. The prevalence of specific type of mental health problems is influenced by the nature of immigration experience in terms of adversity experience before, during, and after resettlement. Specific challenges in migrant mental health include communication difficulties because of language, cultural differences, the effect of cultural shaping of symptoms, and illness behavior, which is different and definitely has a cultural impact on how people come out and explain their symptoms and illnesses, and also their behavior on diagnosis, coping mechanism, and treatments. Differences in family structure and process affecting adaptation, acculturation, and intergeneration conflicts also affect the healthcare narrative of individuals. The aspects of acceptance by receiving society, that affect employment, social status, and integration. These are some of the other factors which do affect the healthcare delivery as well as the healthcare effects of an individual. Between 1986 and 2013, many legislative documents have addressed the issue of healthcare and immigration. I will summarize the four most comprehensive acts, which are the Emergency Medical Treatment and Labor Act, EMTALA, which was signed in 1986. EMTALA stipulates that any person, regardless of his or her legal status, insurance status, or their ability to pay, when they present to the emergency room, they must be medically stabilized before discharge or transfer to another facility. This law was designed to prevent hospitals from transferring uninsured or Medicaid patients to public hospitals without providing a medical screening, examination, and without ensuring that the patients are stable for the transfer. In 1996, the Personal Responsibility and Work Opportunity Reconciliation Act, the PROWORA, was signed. But before that, we had the Permanent Resident Under Color law, which applied to persons whom United States acknowledged were illegal, but for whom country is not actively pursuing deportation. Under this status, these undocumented immigrants were granted access to many public benefits. However, in 1996, the PROWORA eliminated classifying undocumented immigrants as precol status, thus terminating their access to certain benefits like the welfare programs and the Medicaid benefits. Some states appeal this and continue to grant precol status to undocumented immigrants. However, most of the states have limited ability to do that. In 2013, Border Security, Economic Opportunity, and Immigration Modernization Act, which is the S744, was passed. Its three primary goals are to enhance border security, to renovate the immigration system by integrating the current undocumented immigrant population, and to streamline the citizenship process for only highly skilled and educated persons. Undocumented immigrants who have lived in the United States since 2011, according to this act, will be addressed as registered provisional immigrants or RPIs. After some regulation and restrictions, this act does not address healthcare for persons who are identified as registered provisional immigrants. The challenge of providing care to undocumented immigrants will continue and may even increase as these individuals will come out of the shadows and be more likely to seek primary care, preventive health care, and eventually, in certain situations, specialist care. In 2014, Patient Protection and Affordable Care Act has been under, since 2014, this act has been under intense scrutiny and debate regarding healthcare for undocumented immigrants and the registered provisional immigrants and persons on visa. Despite much debate, there has been no conclusive answers to cover care for these vulnerable individuals. So there are some barriers to healthcare in the migrant populations. Mostly, some barriers are specific to undocumented, some immigrants, some specific to refugee immigrants. And most of these barriers are within the realm of policy, health systems, financial limitations, migrant stigma, language barriers, and fear of deportation. So we're going to cover policy, health system, and individual barriers. With the unprecedented international migration seen in recent years, policies that limit healthcare access have become prevalent. Barriers to healthcare for undocumented immigrants go beyond policy and range from financial limitations to discrimination and fear of deportation. Factors such as conflict, discrimination, lack of employment opportunities in countries of origin contribute to the migration pattern. Today, countries have used a variety of strategies to dissuade immigrants from crossing their borders, ranging from border patrol to identity checks, detention, and deportation. With the unprecedented rates of migration, policies that de incentivize migration have spread to healthcare as well. When we explore the barriers faced within the healthcare systems, barriers include bureaucracy obstacles, including paperwork and registration systems, um, alternative care availability in, in situation of safety net is generally limited and the system is overwhelmed. Finally, there is evidence of widespread discriminatory practices within the healthcare system itself. At an individual level, barriers focus on immigrants' fear of deportation, stigma, lack of capital, both social and financial, to obtain services. Undocumented immigrants face cultural and social barriers in obtaining care. One major cultural barrier is language. The other is social barriers often encountered are difficulty keeping medical appointments because of an irregular work schedule, and of course, fear of being reported, fear of deportation, and exposure to law. Recognizing and appropriately treating mental health problems among new immigrants and refugees in primary care poses a challenge because of differences in language and culture and because of specific stressors which are associated with migration and resettlement. There are pre migration, migration, and post migration mental health challenges focused by both adults, faced by both adults and children, ranging from pre migration economic challenges to disruption in the social support to post migration stresses of family adaptation, discrimination, social isolation. So there's a whole range of variables that play into uh, from the pre migration time to the settlement time that affect the mental health issues. So there is a myth that immigrants overuse healthcare and healthcare services in the United States. The reality is that immigrant workers underutilize health services such as going to the emergency room or seeing a doctor. This is probably getting worse with the recent immigration crackdowns, which make immigrants afraid to get health care that they are entitled to and they need. It's also worth noticing that immigrants do contribute towards Medicare. They pay a larger share of their care out of pocket for their care out of pocket than people born in the United States. And undocumented individuals demonstrate less use of healthcare than US born citizens and have more negative experiences with the healthcare that they have received. Thank you all for your attention. I will be happy to take questions. And wow, these questions are rolling in fast. Let's address some of these. So, one of the questions is, what are the effects of Affordable Care Act on undocumented immigrants? Until they receive full citizenship, neither undocumented immigrants nor the RPIs, who are the registered provisional immigrants, will gain access to healthcare under the Affordable Care Act. This will be exempt from the mandatory fee imposed on uninsured citizens, and they will be unable to purchase health care insurances. The Affordable Care Act can be expected to have several direct and indirect effects. The Affordable Care Act also calls for decreased reimbursements to disproportionate share hospitals, DSHs, under the assumption that most persons will be insured. In theory, this will reduce the money that is available to care for undocumented immigrants and possibly place the safety net hospitals at jeopardy for hospital shutdown or withdrawal of certain services. Some states with large undocumented populations are possibly going to get burnt of these changes than some other states. Okay, so we have another question. What measures do you recommend for addressing healthcare barriers for undocumented immigrants? Good question. So we have to basically have an um, an approach which is a multidisciplinary approach to this issue. There are numerous barriers. First of all, it's important to identify those barriers, to understand those barriers, understand the cultural relevance of those barriers. So, the barriers to healthcare for documented and undocumented immigrants are same in certain areas and they are very different in certain areas. Considering the barriers, some of the recommendations are advocating for policy change to increase access to healthcare, providing novel insurance options, expanding the safety net services. Extremely important that they're well funded and they provide proper healthcare. Expanding the safety net services, safety net hospitals, and the services that they provide. We also need to train providers to better care for immigrant population, understanding the language barriers and associated factors with the language barriers, addressing cultural competencies by the providers, and educating the undocumented immigrants to understanding and navigating the system so that they do not have to use emergency care when they need health services. So, one of the questions is, are the immigrants a burden on the healthcare system by bringing in infectious diseases, and are they motivated to migrate from their countries of origin due to health reasons? Again, a good question. In fact, there is no evidence that people migrate in large numbers to access healthcare. That's a very, very small percentage. And if they do have that financial well being to take care of it. Instead, they come to escape violence and persecution. And for better quality of life, economic stability, or to reunite with their families. Immigrants are thought to be sicker than non immigrants and the source of dangerous diseases. These claims are also false. Immigrants as a class tend to be healthier than the native born population and have lower healthcare costs. Moreover, while some diseases can be imported into the US, they are as likely to come from travelers, coming from international travelers, international commerce, trade, as they can come from immigrants. Okay, we have another question. How does various cultures affect health and illness? Right. So, because immigration often brings people together from different cultural backgrounds, it is important to give explicit attention to cultural dimensions of the illness experience. Place of origin can affect exposure to endemic diseases, childhood immunization, records could not be available, or children might not get proper childhood immunization and healthcare experiences. Culture can profoundly influence every aspect of illness and adaptation, including interpretations of and reactions to symptoms, explaining the illness, the patterns of coping with the disease, of seeking help, adherence and compliance to treatment, styles of emotional expression and communication. All these factors are important variables and should be considered by healthcare providers. Also, immigrants tend to use multiple sources of help which are relevant to their cultures. So they could be using traditional forms of healing. If medications are prescribed, the healthcare providers should inquire about whether the patient is using any home remedy or complementary medicine that might interact with the metabolism or effectiveness of the prescribed drug. Broad questions about use of any medications, food, substances taken for health or medicinal purposes can be followed by specific questions. And finally, questions about previous or ongoing consultations with a healer or helper or a physician, they can also help us understand the effect of health and illness. I'm going to take this last question, which is, are there special health challenges faced by refugees as compared to other immigrant groups? So this is, again, a very important question. I'm glad somebody asked this. Um, Refugees face particular challenges, especially with regards to their mental health needs. Under US law, refugees are defined as those who have fled their countries due to well-founded fear of persecution. Persecution. So, for reasons of race, religion, nationality, political opinion, or affiliation with certain groups, or lifestyle choices. While there is a public misconception that refugees automatically gain entry to the United States, merely by having fled any violent or unsafe country, the reality is that they must undergo an extensive education process. Of the 21 million refugees in the world at present, only 1% are referred for resettlement consideration by the United Nations High Commission on Refugees. Refugees are then subjected to an extensive evaluation process with the US Citizenship and Immigration Services to determine their eligibility for refugee status. Rates of mental health difficulties amongst refugee groups are very, very high. Many refugees have experienced a range of traumas prior to leaving their home countries, including detention, torture, gender-based violations, or having been the victim or witnessed an extraordinary violence. This process of plight often displaces and separates families and communities while exposing refugees to additional threats of violence, loss of property, and disease. Another factor to understand is for those invited to resettle in the US, the post migration period can be unexpectedly stressful due to acculturation difficulties and disappointments in expectations. As a result, refugees are at increased risk of developing serious psychiatric disorders such as post stress disorders, major depression, and a variety of anxiety disorders, with rates varying by torture experiences and culminative exposure to trauma. Thank you so much for your attention, and I hope you dedicate more time and research to the study of this important subject. Thank you very much.